بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. I'd like to welcome you all for Grand Round today. This is, I think, the second in present Grand Round, so maybe it takes time for people to adapt, get from the Zoom mode to real attendance in the auditorium. Today's lecture will be about how Oculoplastic collaborate with other surgical specialty in managing orbital disease in surgical perspective. The Grand Round will be given by Dr. Hattan AlKhiary, who is a senior Oculoplastic consultant at King Abdulaziz University Hospital and former medical director of King Abdulaziz University Hospital. He's going to share his experience with working with ENT, neurology, neurosurgeon, and other subspecialty. Looking forward to listen to your experience and hope you all enjoy it.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. Good afternoon, ladies and gentlemen. Thanks for coming. Actually, it's good to be back to KKish and physical Grand Rounds. Today, inshallah, I'm gonna do like a different Grand Round. We're gonna share some cases that we have participated in with other specialties. What I mean by other surgical specialties is non-ophthalmology, like neurosurgery, as Dr. Sahibani mentioned, neurosurgery or ENT or plastics. And then we're gonna talk like 1 or 2 slides for each case. So mainly, most of the presentation is gonna be pictures. Okay. So first case. This is a 32-year-old gentleman, previously healthy, referred from ENT. He has noticed that his left eye is smaller than the right eye for a couple of months. He also gave history of blurry vision for the previous couple of months, but because he is non-Arabic speaker, we could not get enough sufficient information by history. On examination, he's 20/20 in the right, his vision in the left eye 20/60 with pinhole 20/30. So if you could concentrate with me on the photo, he has superior fullness on his superior sulcus in the left eye. If you could also appreciate that the eye is pushed down, you could compare both corneal reflex here. So the left eye is pushed inferiorly for 2 millimeters, and he has 2 millimeters of proptosis as well, with limitation of supraduction. For the residents, when you're in doubt, if you're in doubt about the proptosis, a good trick in the clinic is to ask the patient to do a chin-up position like this and to look up. And you come from down and look for the eye position. This is in case if you're like in a hurry or you don't have exophthalmometer. So it gives like a good rough estimation if there is proptosis or not. And I think you could appreciate with me that his left eye is proptotic a bit compared to his right. And this is him when he's trying to look up in supraduction. His imaging showed. I'm gonna show his images. This is the axial cut of his CT scan in sagittal. Let's concentrate first on the coronal one. So what's different about this case? Now, as you notice that the patient is healthy, he is not febrile, he is not sick, and he has been having these symptoms for months. At least this is what we could get from history. On examination of his CT scan, you will see that there is a complete opacification of all sinuses in his left side. But what's unique about this is the heterogeneity of the opacification. So it's not a homogeneous opacification of his sinuses. There is a heterogeneity here. you could really appreciate it. Not only this, the medial and the orbital floor and the orbital roof are really invaded by this expansion of his sinuses, which gives an explanation to the malposition of his eye ball or the globe. So the same thing in the axial cuts. You could see how stretched is his medial rectus from the expansion of the sinuses and the violation of the orbital walls. Now the last thing I'm going to ask you to concentrate here on the sagittal aspect, that he has a subperiosteal collection coming from his frontal sinus. Now look here carefully. You would see that the roof, the orbital roof, is already violated, and there is already escape of the material from the sinuses, from his frontal sinus into his superior orbit, which gives this superior subperiosteal collection and causing the eye symptoms. So this is not a typical acute bacterial sinusitis or the orbital psoriasis that we usually see in collaboration with ENT. These findings are specific for a specific entity of sinusitis, which is called allergic fungal sinusitis. So diagnosis was already made by ENT, and the reason that they're referring this patient to us is they're planning to take him to surgery, to do functional endoscopic sinus surgery, but they cannot reach this collection endoscopically. There's no way they can reach this. And if they want to do a good treatment, they should get rid of the whole disease. So the reason for referral is the superior subperiosteal collection cannot be reached by endoscope, so they ask for our help and assessment. So the plan before surgery was to do FES, or functional endoscopic sinus surgery, by ENT, and immediately after them, in the same setting under GA, we will do drainage of the subperiosteal collection. Now, all the time, I'm not saying abscess or pus, because this is not abscess. It's a collection, it's a thick collection that is unique for this disease entity. So we did a subbrow incision. Further blunt dissection was done until we reached the superior orbital rim. This white tissue is the periosteum, and we opened the pocket, let's say, and immediately we noticed the presence or the accumulation and the descent of a very thick, heavy mucinous secretion, which is different from the regular pus that you usually see when you open the pocket of a subperiosteal abscess. It usually just pops up. So this kind of material was just flowing down smoothly. So I'm showing a video, a 1-minute video here. The one who's taking the photo is the resident of the ENT. So originally I was trying to evacuate it with a suction, and then we thought maybe for the recording purposes, let's stop suctioning, and I'll just try to put some pressure with the periosteal elevator or the Freer elevator, and you will see immediately the descent of this very thick, very heavy, yellowish mucus material that is filled with the allergic, with the fungal element. So in 2 weeks post-operative, this is photos. The eye is back to its position. His vision improved to 20/30 from 20/60. His superduction is almost full, and there is no more proptosis. Of course, for this disease entity, they need to put the patient post-operatively on systemic steroid and steroid inhalers as well. The local or the topical steroid that they use as inhalation is not enough for this kind of disease. They need to put the patient on systemic steroid. I would advise the residents to have a look on this interesting article. This, I think, if I'm not mistaken, it was the thesis of Dr. Ahmed Al-Araj. It was published by him and his collaborators, co-investigators, Dr. Adis Hibani and Dr. Yasser Al-Faqi, at the OPRS, the Ophthalmic Plastic Reconstructive Surgery. It illustrates the ophthalmic manifestation of this disease entity. Because this is an ENT disease, but it's important for us in ophthalmology because we see this if you're practicing in a general hospital or where an ENT department is around, you will see a lot of these cases, especially in hot areas like our climate in Saudi Arabia. So in brief, allergic fungal sinusitis is a chronic, non-invasive. By non-invasive, we mean it does not invade the nasal mucosa. So that's why they call it non-invasive. Chronic non-invasive autoimmune reaction to the fungal element in immunocompetent young patients. Serologic testing usually shows elevated IgG and IgE levels associated with peripheral eosinophilia. It accounts for 7% of all sinus disease that need surgery. Now, the pathophysiology of this is not fully understood, but we think that the fungi becomes deposited in the sinuses and then it starts proliferating under anaerobic conditions. And after that, the patient will develop an allergic immune reaction to this fungal element in the sinuses. The hallmark of the disease is, as I mentioned, the accumulation of eosinophil-rich allergic thick mucinous secretion that contains the fungal particle in histopathology. But you could see it even in gross examination. It's type 1 and type 3 hypersensitivity reaction to the fungal antigen. And we think the same process, the pathology of this disease is the same pathology of the allergic bronchopulmonary aspergillosis. And believe it or not, the most common isolated fungi here is Aspergillus as well, which was even shown in the previous article that I showed. Now, how would the orbits get involved? Now, because of the expansion of the sinuses, it is usually associated with bony destruction, secondary to the pressure effect first, and then by demineralization of the bone of the orbital walls. Secondary to that, allergic fungal mass that usually takes months or years to get big or to expand. Now, if you don't treat this, if they don't treat this, the ENT people, if they don't treat this, definitely it's going to reach the orbit and definitely it's going to reach the brain. And I think we have seen many cases that reached intracranial extension at King Abdulaziz University Hospital from this disease. Previously, we thought only 17% of this disease would come with ophthalmic manifestation. But in the previous study, Dr. Al-Araj and his co-investigators, they reviewed 100 patients from King Abdulaziz University Hospital ENT department that all had underwent surgery already and diagnosed already with this disease. And now we think it's much more common. In that previous study, 34% of patients had ophthalmic manifestation. Most common ophthalmic manifestation are proptosis, diplopia, ptosis, epiphora, and visual loss from optic nerve compression, as well as ophthalmoplegia. The most common sinus involved were ethmoid and maxillary sinus, but believe it or not, most of the time you would see a pansinusitis or involvement of all sinusitis, of all sinuses. The goal of surgery is not to eradicate the infection because it's not an infection per se, rather than an immune reaction, but to debride the fungal mucin and open the sinuses for better ventilation in the sinuses, and to provide a better delivery of the topical steroid that they usually prescribe post-operatively, and also to confirm the diagnosis by sending histopathological slides. The role of antifungal is controversial. Nowadays, most people would not give because of the chronicity of the condition and the liver toxicity of the antifungal. Recurrence is high, and it ranges in literature between 28 to 58%, and many of those patients will require more than one surgery. Usually the revisions or the repeated surgeries are done by ENT alone, usually. Why we're presenting this today? Because as ophthalmologists, you might be the first one who encountered this disease, because those patients are usually healthy, they don't have a lot of complaints from their sinuses, they might present to your clinic or my clinic when they start to have ophthalmic manifestations. So keep in mind allergic fungal sinusitis. We'll shift gears now to another case. Case 2 is the Professor Yasser Al-Faqi case, and with his permission, I'm presenting it today. This 3-year-old nice boy was diagnosed from birth with Frontonasal Encephalocele or Encephalocele. The patient had first surgery at 10 months of age by neurosurgery, in which he had craniotomy and repair of the anterior cranial defect fossa by a bone graft from the skull itself. So part 1 is done, defect was closed, neurosurgery 50% finished their job. And then they referred the patient to a ENT department for this huge nasal mass. On examination, you would see a cystic swelling. A cystic swelling that starts from the root of the nose and all the way through his bridge. Not only this, also the medial orbit is also involved, and if you could see that the patient orbits are separated apart. This is a condition we call hypertelorism. So the patient on ophthalmic examination has hypertelorism. He's complaining he had tearing and discharge since birth, which gives you an impression that this mass is affecting his lacrimal system as well. Dye disappearance test was definitely delayed, and Dr. Hassan Al-Udan thankfully did a cycloplegic refraction which showed an isometropic, astigmatic anisometropia, especially in his left eye, because most of that mass is going into his left orbit. Of course, it doesn't take a brainer to tell you that this 3-year-old child who has an isometropia cannot use glasses because of his nose condition. So there is no glasses would fit here. And we know if we don't interfere, then the patient vision will start to deteriorate. So it's a huge mass coming from the anterior cranial fossa. You could see that it's involving mostly the nasal area, but also in the left orbit, extending into his left orbit and abutting his medial rectus muscle, you can see here. The CT scan pictures are not very helpful, but it tells you if there's any bony abnormalities, and you can see the mass as well as here. I had too many slides to show for the imaging, but again, it's not an ophthalmic disease, so it's we'll concentrate on the ophthalmology part here. So the first part, as I mentioned, was done already at 10 months of age by Professor Isam Al-Jamal from Neurosurgery Department, King Khalid University Hospital. The second part was the excision of the nasal part, or the nasal component of this mass with reconstruction, and for this we would need a team from ENT, ophthalmology, and neurosurgery as well. So our concern, ophthalmology concern or oculoplastic concern, was to evaluate the lacrimal system during or intraoperative, and to stent if possible, of course after they remove the disease. If we failed, we plan for DCR at a later stage. So this is Dr. Yasser Al-Faqi. I'm taking photos here. This is Dr. Yasser Al-Faqih from ophthalmology, Dr. Professor Isam Al-Jamal from neurosurgery, and this is the main surgeon, Professor Ahmed Al-Ammar, pediatric otolaryngologist from the ENT department. And you can see that they started to isolate the mass and to bluntly dissect it. It was really bloody. This is the mass. You can see it here more clear. It took some time for both neurosurgery and ENT team to finish this, and by the end of the excision or the section, they resected a 6 by 3 by 2 centimeter mass, all together in one as one piece. And we would assume that these are they contain already the medial or the orbital part or the orbital component that I've shown in the radiology. And this is his photos post resection. Now the ophtha team came on, Dr. Yasser Al-Faqih, trying to evaluate his lacrimal system, and here he goes, stenting him both upper and lower canaliculi. You could see the stent that is coming through the common canaliculus here. We fixed the stents, and then they started reconstructing his nasal flap, which was, you could see that they did a flap here to put everything back when they finish. So encephalocele is a congenital neural tube defect where a sac containing either brain, meninges, or CSF fluid forms outside the skull due to a bony defect. So most of encephaloceles you would see are congenital, though acquired encephaloceles may result from trauma or tumors or even surgery. It has been already associated with more than 30 different syndromes. For instance, or for example, like Freezer syndrome and morning glory syndrome, and I've put these because we know that they have some ophthalmic manifestations. Torsion fiction is the main reason of involvement, or the main maybe believed factor that have been already involved in many cases. And in Saudi Arabia, because of high rate of consanguinity, we see this even more frequent. The most accepted theory for origin of this problem is a defect or a problem of the separation of the surface ectoderm from the neuroectoderm after closure of the neural tube defect. And usually they could detect this during the intrauterine life by ultrasound. Classification could be done according to the location. The famous occipital or the posterior encephalocele is away from the eye, so we will not discuss here. And that type is usually associated with many neural or neurological deficits. The anterior part depends on which bones are involved, but has many types: frontonasal, nasoethmoidal, nasoorbital, transphenoidal, and so many types. Complication of this, it might lead to CSF leak, meningitis, seizures, hydrocephalus, or developmental delay. The treatment goal is the surgical repair of the bony defect. So once you do this, once they do this, the neurosurgery, usually the patient will not have or will not develop those complications like meningitis and seizures and the CSF leak. At a later stage, usually they do deal with the excess skin and remove the non-functional brain tissue. I've put this is not related to our case, but I've put this because sometimes, and it is important for you as an ophthalmologist, if you encounter a congenital dacryocele or dacryocystocele, to put that in mind. Now, typically, or classical teaching here, is the dacryocystocele is usually below the medial canthus. So this is a child born with congenital, they will call you from ICU or in ICU or whatever, with a congenital lesion that is totally below the medial canthus. So you know that this is dacryocele. Encephalocele will usually be above the medial canthus. So you can see this kid or this child has broad nose or nasal bridge, broad nose here, and you can see that the mass is extending even above the medial canthal tendon. So I've put this slide for the discrimination or differentiation between both conditions. طيب, case number 3 is again with permission of Dr. Yasser Al-Faqi, Professor Yasser. This is a healthy lady. She's 47-year-old. She presented to our clinic complaining that she feels that her right eye is smaller than the left eye. And believe it or not, in oculoplastics, we hear this a lot. A lot of people, they come to your clinic and they think that their eye is smaller. This is the complaint. But the assessment or the diagnosis is going to be different in a lot of times. So not smaller eye means smaller eye. So in a lot of time you will have like an illusion because of a bony abnormality, because of a lid abnormality, because of a globe malposition, that sometimes give an illusion for the patient that her or his eye is smaller. She had no pain or diplopia. Her examination was not was only significant was for the following. Her vision was 20/30 in both eyes. And let's concentrate a bit here. Now, if somebody would say that, yes, Hattan, she has ptosis because her corneal reflex here is almost like MRD is almost like 1, and MRD here is 3. We would say yes in the beginning, but when you concentrate more, if you concentrate more in the eye ball position, not the corneal reflex, you would see that the eye is pushed up, and that's why the MRD is decreased, or the corneal reflex is close to the lid margin of the superior lid. Yani, concentrate more on the inferior limbus here. See how is the inferior limbus is different from this lid. And when she's looking up, you would maybe appreciate that she's a bit proptotic. The eye is pushed out more in superior gaze. So she had 3 millimeter of right proptosis and 2 millimeter of superior globe dystopia or superior displacement. Her muscle, her extraocular muscle was full, and this is a condition of pseudotosis. So this is not a true ptosis because of lid abnormality, but this is a pseudotosis because of a globe abnormality or globe malposition. So imaging was done, and we could see that the patient had a large maxillary sinus mass. We would call it mucocele in this case, a large mucocele that is already making her orbit smaller, and that's why the eye was pushed out and up. So the mucocele was already started already to affect her orbital floor, her nasal, her medial orbital wall as well, and that's why the globe got affected. There is no eye disease per se, but the eye is a victim here, secondary to this maxillary sinus mucocele. So seen by ENT already, the plan was to go in one shot, like under one same sitting under general anesthesia. The ENT will do FES. They will excise this. They will do functional endoscopic sinus surgery. They will take the mucocele out and drain it, and then the oculoplastic team would join. I'm taking photos here. Dr. Yasser is the surgeon, so we elected to do a transconjunctival approach. This is traction suture of the lid margin. This is the transconjunctival approach. We reach the inferior orbital rim, as you can see here, and you can see the defect, the shadow or the dark appearance here, which, because we're looking, I'm taking photos through the maxillary sinus. And to believe that this is the maxillary sinus, Dr. Yasser is passing the suction, the suction from the nose, and it's coming through her from the defect or the bony defect in her orbital floor. So the ENT finished their part, and then Dr. Yasser took over. We thought that this should be repaired because otherwise it's going to give her enophthalmos post-operatively because of the orbital floor defect. So he elected to repair this with a mid-pore implant, and he likes to use titanium screws, and this is what has been done for orbital floor reconstruction. So maxillary sinus mucocele. Mucoceles in general are epithelial-lined mucus-containing sac inside the paranasal sinuses. They typically arise from chronic inflammation, i.e. chronic sinusitis, scarring or surgical manipulation. Usually they're expansile, so the patient, they're not like in a bad situation, or they don't have like a lot of complaints. But because of the expansion of the sinuses, it causes bony erosion, and therefore it should be removed or drained before they reach the orbit or the brain. 60% of cases, frontal sinus is the one involved, ethmoid 30% and maxillary 10%, so this is one of the rare 10% cases. Nasal obstruction and facial pain would be the most common symptoms that the patient would have. When extending to the orbit, it may cause displacement to the eye, proptosis, ptosis, or even pseudotosis, as the case we have shown, double vision and epiphora according to the extension of the mass. And definitely the treatment is surgical. Okay. Case number 4. Again, ENT case. So 9-year-old girl with some diagnostic dilemma here. They couldn't know what's going on with this girl. So 9-year-old girl has this nasal mass growing rapidly over 1 month. So over 4 weeks, the patient presented with this picture. And we have compared her pictures before and after. But she's not on pain. You could see her smiling in the face, in the photo. So she has no pain. She has no of the complaints of whatsoever. Her examination of her ophthalmic examination is completely normal, 20/20 vision with everything normal. And there was no history of trauma. There's a cystic mass that is involving the right side of the nose as well as the nasal bridge. That is not non-tender, and there's no skin manifestation or changes over it. And it's very close, as you can see, to the medial orbit and the medial canthal tendon. Again, her ophthalmic examination was normal. So this is a superior picture, if would add anything to you in the assessment, and this is her lateral picture. CT was not very helpful. And on MRI, they found that the patient has a soft tissue irregular mass that was really vascular and enhancing with contrast, and it's in very close proximity to the globe. You can see here, and you can see here as well in the coronal sections. But the eye is still not involved even in the movement. Alhamdulillah. So they had a dilemma of the diagnosis. So they don't know what is this. But of course, if you have an aggressive disease that is growing rapidly, you need to put oncology or malignant processes in your differential. If you ruled it out, then alhamdulillah, you can just relax. But they couldn't know what's going on here, and they decided to take the patient for surgery. When we discussed with them what was their differential, they said this could be a hemangioma, although it's very unlikely because we know that hemangioma is slow growing, and the place is not typical. Hemangiopericytoma because it's fast growing, so they put this in their differential. Of course, as ophthalmologists, we know rhabdomyosarcoma is a great mimicker, so it can happen anywhere in the head and neck, close to the eye, in the orbit, close to the orbit, anywhere. And she is at the correct age group. So rhabdo was one of the differential, although it's very vascular for rhabdo. Papilloma or inverted papilloma because they see a lot of those tumors in the nasal cavity and the sinuses. So why they involved ophthalmology? So the ENT surgeon, or the head and neck surgeon, Professor Salih AlKhiary, he contacted us and he said, listen, I'm not quite sure if I could separate this from the medial canthal tendon. It might need reconstruction after we finish. That was their concern. From our concern was, yes, the medial canthal tendon could be of concern, as well as the lacrimal system. So what happens with the lacrimal apparatus after they remove this, we don't know. We need to be there to examine and maybe to interfere. So unfortunately, because I was operating alone in the ENT room with the ENT team, I couldn't take intraoperative photos here. But surgical resection was done by ENT, and the mass was sent for pathology. And I put one reinforcing suture of for the medial canthal tendon, but it was okay. It was not destroyed or destructed by the process of the mass. And I elected to stent the patient, so bicanalicular Crawford stenting was done. Stents were removed in 4 months. The patient had no tearing of whatsoever. She was 2020 as she presented. This is her photo in a year time. كبرت ما شاء الله, so اتحجبت. This is her photo in 1 year. She doesn't have a bad scar, unless if you look at this very closely and from the lateral side. Again, I removed the stent in 4 months, and alhamdulillah, she did very well. I followed her for over a year and a half, and the pathology diagnosis came to be of aneurysmal bone cyst, which is very rare for us in ophthalmology to hear of. It's a rare expansile blood-filled bony lesion that usually affect the long extremities, either the arm or the thigh or the leg, and very rare to happen in the head and neck area. But you know, there's always the first time. It represents only 2% of all the head and neck aneurysmal bone cyst represents only 2% of aneurysmal bone cyst all over the body. Its potential for rapid growth and bony destruction and extension to adjacent structures warrant early intervention. This is what happened in our case because of the diagnostic dilemma. So they elected to take the patient to OR. Etiology is still not clear. It is presumed that it causes by that there is a hemodynamic alteration leads to venous obstruction at the bony level, and then it causes like a small, very low shunt arteriovenous fistula with bony resorption, and then secondary, and then the mass would appear. Complete surgical resection is the treatment of choice. The recurrence rate ranges between 10 to 30%. Last time I think they saw her in 2 years back maybe. She had no recurrence and the patient was doing fine. So this is my last case. Case number 5. A nice gentleman presented. He's a 20-year-old healthy gentleman who was referred first from DISH, Dahran Eye Specialist Hospital, and then was admitted by neurosurgery at King Khalid University Hospital. So he did not present to ophthalmology first, he presented to neurosurgery. Because of, according to the referral, they admitted the patient. The patient had diplopia on his right gaze and up gaze for the last 8 months. So he developed COVID during those months, and he thought maybe because of COVID. He said maybe my vision got a bit blurry, although he's 20/20, but he sees double in right gaze and superior gaze. It was associated with some, what he prescribed, redness here at the caruncle area, if you can see, and I'm going to put a closer view for that. He was admitted at DISH. I think they thought it's an inflammatory process, so he received IV steroid for 3 days and even local injection of steroid. I don't know where, but this is his story. He had no pain. His vision was 20/20. There was no trauma, no previous surgery. In examination, 20/20 both eyes, 15 out of 15 color vision. He had 4 millimeter of axial proptosis And he had reduction in the eye movement. So this is him trying to look up. The eye is not going up. And here, this is him when he's trying to look right. There is a limitation of -2 at least in the adduction. Abduction was okay, so that rectus was fine. And this is a microscope. This is a slit lamp photo of that localized redness. It doesn't fit with any known pathology here, but it gives like the appearance is a bluish hue. It gives like a bluish hue under the conjunctiva, but again, no clue what's going on here. This is a closer photo for the caruncle and the underlying angry vessels here. This is coronal MRI. It showed the intraconal mass that was enhancing. We believe that after discussion with the neuroradiologist, that the mass is arising from the medial rectus, and it could not be separated, at least radiologically, from the medial rectus muscle. This is another look. So that spindle-shaped huge mass that was extending from anterior till maybe all the way back to the apex, and it was enhancing with contrast, with an early enhancement of the contrast, which is against the hemangioma that we know. And it was really vascular. So I'll stop here. So the patient was admitted by neurosurgery to take the patient for interventional radiologist to try to do ligation for this vascular mass. So that was the original plan. OPHTA was not involved till now. So they did not contact ophthalmology until they failed to do this. So the plan was to take the patient with the help of the interventional radiologist to ligate this or immobilize it or whatever. And you could see that this is the internal carotid artery. This is angiogram, internal carotid artery. And we know from the basic science that the ophthalmic artery is the first branch that comes from the internal carotid. You can see that the mass is mainly and exclusively supplied by the ophthalmic artery. So the interventional radiologist said, there's no way we can do this, otherwise he would end with blindness. And he's 20/20. So the attempt was aborted after they saw the vascular supply that comes to this mass. Then they contacted ophthalmology and they informed us that we're going for surgery. We need you to come and help. So we formulated a team of ophthalmology, neurosurgeon, and ENT that were already involved because the patient was admitted under their name at King Khalid University Hospital. And we had an initial plan that we will take a biopsy and we'll send it for frozen section and we'll see the result. If it's benign, we'll go ahead and excise everything. If it's malignant, we'll just hold there because it depends on the final diagnosis. So this is me and Dr. Abdelaziz Al-Rashid. Abdelaziz Al-Rashid from ENT and Abdelrazak Al-Ajlan from neurosurgery. This is our team, ophthalmology team from King Abdelaziz, operating up there at King Khalid. This is Dr. Rawan, fellow. And this is a closer look to the mass. That was so we started transcaruncular as we planned, and we took a biopsy. The one who's taking the photos here is the Dr. Attar, the neurosurgery resident, and he's taking it with the scope of the neurosurgery. So you will see that most of the photos are in a circle. So this is the biopsy. This is me getting 2 pieces. So we sent it for frozen section. No clear diagnosis was given, but they told us that this is definitely malignant. We discussed with the team, and we decided to call the day off, and we stopped until we get the final diagnosis, which came to be alveolar soft part sarcoma with aggressive behavior. Thanks for Dr. Hind Gattan. She helped us reaching the final diagnosis. And Because of the rarity of this disease in the orbit, they elected to discuss this at the tumor board, the neurosurgery team. The oncology or the radiation oncology or the board, the tumor board, they advised, according to their experience with the other parts of the body, because the cases reported in the orbit are few, that we should do a complete surgical resection with postoperative radiation. And this was done through craniotomy because of the very vascular mass and the expansion or the extension till the orbital apex, and we need to make sure that we did not leave anything there. So ENT approach, trying to get that endoscopically through the nasal, the sphenoid sinus, is not a good approach here. The best way we thought is doing a craniotomy and orbitotomy to take the completely resect the tumor, and followed by radiation therapy. That was done for 6 months back, and then the patient started to receive the radiation therapy, and he's doing fine till now, alhamdulillah, with no recurrence. So alveolar soft part sarcoma represents only 1% of all soft tissue sarcomas around the body. Most commonly, it affects the lower extremities as well. In children, if it happens, it affects the head and neck, and usually the orbit is the preferred site. I remember I saw a case with Dr. Ayman Ayubi during my fellowship here at Kekish. And according to Dr. Hind, she has 2 other cases. All are children in the orbit with alveolar soft part sarcoma. Orbital cases usually manifest as a slow-growing mass resulting in proptosis. So yes, this is malignant, but it's a slow growing usually, and it does not metastasize early. So usually most of the disease process will be local. It gives globe displacement, proptosis, redness and edema of the conjunctiva. This is what we also had in the gross examination. Ptosis, decreased vision, and the gross examination of this tumor usually gives a relatively circumscribed lesion that is vascular and tend to have a capsule. Tumor usually often bleed profusely during biopsy, and I'm quite sure Dr. Rawan remembers this. I think he bled almost like 400 cc just only from the biopsy that we took, because we took a fresh frozen pieces for fresh frozen, and then we took another one for the final diagnosis when they said that they couldn't reach a diagnosis with the fresh frozen. Radiologically, it gives an appearance of well-defined mass with smooth outline and bright enhancement. Wide local excision is the recommended way of treatment. In cases of recurrence or incomplete excision, exenteration would be the treatment of choice in this case. Poor prognostic factor include increasing age, so the pediatric has a better prognosis than adults. Tumor larger than 5 cc at the beginning and metastasis at the initial presentation, of course, definitely carry out a poor prognosis. Non-orbital alveolar soft part sarcoma usually tend to have poorer prognosis. That was my last and final slide. Thank you for listening. I would love to acknowledge Professor Yasser Al-Faqi for allowing me presenting some of his cases and the contribution and help of Dr. Rawan Malaika, our fellow, ocular pathologist, our beloved Dr. Hind Gattan, of course. Those surgeons participated in those cases, Professor Isam Al-Jamal from KQH Neurosurgery, as well as Dr. Abdurrazzaq Al-Ajlan from Neurosurgery, from the ENT team at King Abdulaziz University Hospital, Professor Ahmed Al-Ammar, pediatric ENT, head and neck surgeon Dr. Salih Al-Dhahri, and the rhinologist Dr. Saad Al-Saleh. Thank you very much.
Thank you so much, Dr. Hattan, for these interesting cases. Anybody has a question? Any question? I have a question. Dr. Hattan, for the last case with the sarcoma, why you didn't go for exenteration immediately? Because what happened when you remove the mass, the function will, the eye will be affected because you need to remove the medial rectus muscle, and you're not sure where you really find the complete local resection, especially in the orbit. So the classical teaching says whenever you have a mass in the orbit that's malignant, to do excentrations. What's your experience?
I agree with you, but we offered the patient, but he refused. His vision was 20/20, and still 20/20 after the orbital biopsy. So he went against medical advice, and he took another opinion. I don't know where, to be honest. And he came back then to neurosurgery, and he said, "I'm ready for surgery after 1 month." But he refused exenteration. Now, what's in his favor in this case, that he is still 20/20, and he has no diplopia in primary position. He was seen last time by Dr. Hassan Al-Udan, the pediatric, for orthoptic workup, a pediatric ophthalmologist. Alhamdulillah, he had no diplopia in the primary gaze, though he has diplopia in the right or left gazes. So till now, after 6 months, there is no recurrence, but the patient refused exenteration. We discussed that with them. Well, Doctor, I'm not quite sure. I think at DISH, maybe they thought it's inflammatory, maybe orbital pseudotumor or something. Maybe when he presented to them, it was less than this huge mass. If I recall, he went to them and maybe like 4 months before he comes to Riyadh. Maybe they found like an enlargement of the muscle, and they thought it's myositis that is related to orbital pseudotumor. Admitted, given steroid, no improvement. They thought, no, definitely there's something else is going on there. This is my assumption.
I can answer this. What happened? This patient is resistant to do any surgery. They offer him a biopsy to know what's going on. He said, I don't want surgery. There's a second line of treatment. They offered him surgery of the steroid. So this patient, he's not interested to surgical intervention. This is what the problem, why the delay in management. Any question?
But when he did not improve with steroid, so if it was orbital pseudotumor or like myositis, he would it would definitely improve with steroid. So when it did not improve, they needed to think of something else, and I think the next was biopsy or the surgical intervention.
I have a question. Regarding the first case you showed with allergic fungal sinusitis and the subaeriostal collection, what do you think if we don't drain the subaeriostal collection? Is it going to go or not? My way of thinking is what bringing the mucus in that area is the connection between the sinuses and the orbit. So if that one cleared with the ENT surgery, no pus will come, because what's the source of the pus is the nasal mucosa, not the subaeriostal space or the periorbital.
Absolutely.
And this is what I've been doing recently, is tell them, okay, do it, it will gonna go, and most of the time it goes. So what's your experience?
Well, this is my first and last case that I've drained with the for allergic fungal sinusitis. Dr. Saad Saleh, the operating surgeon, he has very good and large experience with those cases. And he told me, Hattan, I think the collection is large. And I think it's better to drain it. And we're going anyway. So we're going anyway for FES, for functional endoscopic sinus surgery. Would you join? I told him, okay, no problem. The way of thinking is correct. Actually, even post-operatively, when they drain this through endoscopic sinus surgery, some studies showed even like bone regeneration. But will everything go or not? I have limited experience with that. But most of the cases, I would assume, if you take the primary source or you treat the primary disease, would have an improvement definitely in their orbital manifestation.
Yeah, this is what we observe with the reviewing the cases with the allergic fungal sinusitis. So if you drain it, it will go. And the other thing you mentioned, that whenever you have periorbita intact, the bone will grow again. So the defect will be closed even by itself.
Yes, because the periosteum is intact still, alhamdulillah, and the bone usually gets regenerated after you eliminate it. But the strange thing of this disease, although we started maybe to have like a better experience now, is the pathology. You never know who's gonna like recur and who's gonna have like persistent symptoms after the surgery. My personal experience with just few cases, and definitely you know better since you supervised 100 cases with Ahmed al-Araj, is usually recurrences are not for ophthalmology. So usually they don't have of the manifestation. This is what I've been noticing. But again, it's maybe sometimes it's a little bit early to judge because sometimes it needs years to recur. What do you think?
I agree. What happened with patients when you interfere and you go for major surgery? They don't want to go for another major surgery. They took to come yearly, becoming more compliant with the follow-ups and come yearly for any intervention. And this is, I think, what's been my experience. Any question? Okay, thank you, Dr. Hattan, and thank you, everybody. And
Shukran. Thank you.
Looking forward to see you next week for the other grand round.